An associate professor. Oh, yes, should say this session will be recorded. My name is Stephanie Best. I'm an associate professor in implementation science down at the University of Melbourne. And I'm delighted to be introducing this session today. The title of our session today is about translating research into practice in rural and remote contexts, a case study implementing nasal high flow therapy into 3 very remote hospitals. I won't give you any details about the session because Sally and Alice are here to do that. But maybe if I could just introduce you to Sally and Alice. Sally West is a nursing academic based at the James Cook University Central Queensland Centre for Rural and Remote Health. Her current work is around evaluating the implementation of a nasal high flow therapy in remote contexts and also translating that evidence into practice. Sally's a registered nurse and she's been working clinically for about 20 years and in the rural and remote context for about 10 years. Sally's in the throes of finishing off her PhD, which is fantastic, well done, using implementation science methodology, and has become increasingly passionate about advocating for people who live in rural and remote communities so they can access the same standard of healthcare as somebody in an urban context. And Alice Cairns is a senior research fellow at the James Cook University at the Centre for Rural and Remote Health and is on the leadership team for the Northern Australian Research Network. Her current research interests are around developing and implementing place-based models for allied health service delivery in very remote communities. She's an occupational therapist, always good to have another therapist on the call, specialised in mental health rehab and received her PhD focusing on youth mental health at the Queensland University of Tech in 2017. And it says here at the end of my bio that Alice lives on the beautiful Atherton tablelands in far north Queensland. So I had to look that up before I started this session. I have to say it does look rather stunning. Before I go any further, if I could perhaps just do an acknowledgement to country, let me just see if I can just share my screen. And it should be that one. Lovely, you should have a pile of rocks. So I'd just like to do an acknowledgement to country. So acknowledge the traditional custodians of wherever you happen to be calling from some of the people that I've already been chatting with. So already we're there, so we're across multiple states. Macquarie University is on the lands of the Wata Matagal clan of the Darug Nation. I'm down in Melbourne in Naarm, and I'm on the lands of the Wurundjeri people of the Kulin Nation. I'd like to pay my respects to elders past and present and anyone on the call, any First Nations people who are on the call with us today. So without further ado, I will stop sharing my screen and invite Sally and Alice to take it away.
Thank you very much. Sally, are you able to share?
I am. Just split up.
Sorry.
I'm going, so it'll be on screen too. And I will share. Lovely. You take it away, Alice.
Fantastic. And thank you very much. So I think we can move on. We know that this talk is really about a project that is happening in Cape York and Thursday Island. For those people that don't know where that is, have a quick Google and you'll see that it's at the very far north of Queensland, right at that pointy bit and the junction between Australian mainland and PNG. We also want to acknowledge the traditional owners and the custodians of the land around Australia, but particularly Sally and I met and this project started in Weipa on the Western Cape York. And the Alnith people are the traditional owners, collective sort of group of the traditional owners of the Weipa area. So we particularly want to acknowledge their connection to land, sea and community. I will talk very briefly about implementation. I'll get Sally to move on to the next slide, but I will hand over to Sally and she will do the lion's share of the talking. This is really her project and her baby, and I'm there as a support and a supervisor, so I'll hand over to Sally. But before we launch into the actual case study in the project, I want to talk a little bit about why we think that implementation science and research is so important for rural health. And I know I'm really talking to the converted around the benefits and importance of implementation science, but there are three real main issues that drive me and Sally in particular to think about implementation in rural and remote contexts. And first is something that's already been mentioned, which is a drive around equity of access to service. And that requires a particular type of project when you're translating that evidence for best practice into these remote contexts. And you'll hear a bit more about the context we're talking about, which is very, very remote. The other thing is that the models of care in which we deliver, health in rural and remote areas is considerably different. It is not just if we have more people, we would be able to provide the same thing. The way in which we deliver care is vastly different. It is never going to be the same, and it is impossible to think of it as the same. And actually, the community don't want it to be the same. They want us to do things differently that's appropriate for their community. But that means that you can't just take evidence from elsewhere and plonk it in. And when you do see that evidence being taken and plonked in, actually what it does is tend to fragment care. And we see that all the time in rural and remote places. There's really well-meaning projects that are for a particular disease group often. And in our location, it's often things like kidney disease or diabetes, and they have particular really strong evidence around how things should be done. That's great for a small portion, for a portion, but it sometimes just fragments the care for other communities. And lastly, there are real local and contextual implementation challenges. I've talked about workforce, and it is not just about numbers, it's actually about the way we practice and the idea of rural generalism and what that means actually when you're a clinician working in that space. And the other thing is around geographical, and I've put risk, and Sally will talk a little bit more about what we mean, but essentially we are so far away from a lot of services. It means that the distance between us and, say, ICU services or specialist services creates a risk in terms of the clinical decision making for the clinicians on the ground, and that's something that rural clinicians manage every day. But when you're talking about implementing new evidence, it actually has to be thought about in the broader context of all the other risks that that's there for that community and for that health service. So I will hand on to Sally, and she can talk through the project of implementing nasal high flow.
Thanks, Alice. And I just wanted to add to what Alice was saying about us working in Cape York. I've only recently moved away to Central Queensland, but the Ulnath people in Cape York really did drive this project from the outset. I just wanted to pay a good acknowledgement that it was a collective group of women, Ulnath women, who sort of gave me the idea of this project being being worthwhile, because they were frustrated with the current state of service and wanted me to look into this a bit further. So with that in mind, we're going to talk about a smaller, I've got the big whole project, but this is a smaller section of the project. But the aim of this study is to evaluate the implementation of a clinical guideline for the safe delivery of nasal high flow therapy to children with, we call it AHRF, which is acute hypoxemic respiratory failure, in 3 very remote Queensland hospitals. So Thursday Island, Weipa and Cooktown. So what we did was we had found that there was a research team, which was a big research team based in, luckily, Brisbane, called the PARIS team, the Paediatric Acute Respiratory Intervention Studies. And I was looking at how do I implement nasal high flow in these sites that we're in. And I found that this research team had done lots of efficacy studies and lots of evidence-based studies on the use of nasal high flow therapy, starting with bronchiolitis as a disease and then expanding it to acute hypoxemic respiratory failure. And I'll just describe those a little bit later. And I said, oh, I'm interested in implementing what you've learned and applying that to the remote context. And they were delighted to help. So we then made this a subset of the Paris Remote Intervention Studies research team and called it Paris Remote. So what we know about respiratory disease in the north of Australia for children is that we know that across the north of Australia that it's one of the most predominant reasons for retrievals. We also know that Aboriginal and Torres Strait Islander children experience a greater amount of respiratory disease than non-Indigenous Australians. In the north of Australia, in our research sites, so Thursday Island, Weipa and Cooktown, across 1 year, we looked at the initial phase, just to establish the state of play, to figure out what was the initial problem and how many kids are we dealing with. We looked at bronchiolitis, and we found that 108 infants over 1 year suffered with bronchiolitis, and 54 of those infants were retrieved to either Cairns or Townsville. So that's our retrieval sites. Cairns has a paediatric unit, and Townsville we might retrieve if we needed a paediatric intensive care unit. So we found that was actually quite a fairly decent retrieval amount for that disease type. And we know that our 3 sites, so we've got Thursday Island at the top, in the middle we've got Weipa, and down the base we've got Cooktown, and so they're all in the Cape and in the Torres Strait Islands. We know that to retrieve any of those children, they all require some sort of aeromedical retrieval. So like a helicopter or a plane. In some cases, if a child is in one of the outer islands, might be a boat, helicopter, plane. We knew that there were lots of additional layers to bring on if we needed to retrieve a patient. So, you've got to factor in whether there's a cyclone, busyness in the Cape, the plane's broken down, or just taking a bit of time to get there. So we never really can tell by relying on retrieval for access to a treatment. We know that we're taking on additional unknown time frame, an hour, 4 hours, 2-3 days if it's a cyclone and no one can pass. And we also could see, because Alice and I were both living and working in these regions, we could definitely see that social and financial burden of having a retrieval. We really wanted to advocate for that equity of access. And so at the time, we probably started off thinking retrieval sounds like a great idea. That way they can receive that safe standard of treatment. And then we realised soon after that actually, if that retrieval can't, that's all very good and well if you can retrieve. But if that can't come, then you're placing your patients and the community under a higher degree of risk. And there is a treatment out there that we could use, which was nasal high flow therapy, that we thought might be of great value. So to emphasise, these remote contexts don't have ICUs on any of the sites, not even a paediatric ward. It's a general ward for adults, kids, and one site has a high dependency unit, but not really for children. They all rely on retrievals, a plane for retrievals. So you're taking that risk on, and there's always something that can happen to stop that retrieval from happening, like a cyclone. So the disease that we focused on included any respiratory disease that can present to an emergency department acutely that requires oxygen. So that is acute hypoxemic respiratory failure. That includes asthmas, bronchiolitis, pneumonias, or an upper respiratory tract infection. And we could see the value of aligning acute hypoxemic respiratory failure as a disease type with what other research was starting to do. So that's why we decided that disease type. We also knew that nasal high flow had a real good place for us in the remote setting, mainly because of this non-invasiveness profile. I'll just try and get a pointer. Because of this non-invasiveness profile. So you can see that in our rural and remote context, so for us, we're extremely remote for all 3 sites, we had the option of standard oxygen therapy, which is just what you see on TV. It's the little nasal high flow cannulas that have a low flow of oxygen that go through. And then in the remote site, we didn't really have any other options to escalate unless we retrieved. And if we couldn't get that retrieval in time, the only option we had on site was intubation and ventilation. Now, that is a really big deal for us in extremely remote settings. We avoid that at every possible scenario. It's highly invasive, and we are excellent clinicians. I don't want to denigrate rural remote clinicians. We are really great at what we do. However, we don't intubate and ventilate small babies or children as much as they would in a city. In the city, they might have what's called continuous positive airway pressure, which is a little bit less invasive, but we had nothing in between. So until a few years ago, we would have, when we introduced nasal high flow with that lesser invasiveness profile, and it was actually a lot easier to apply, it really changed the way we were able to look after kids with respiratory disease in the remote setting. And but when I say it's non-invasive and it's easy to apply, you actually still need to know how to look after the unwell child. So it's not completely 100% perfect. So, but that is true for anyone who uses nasal high flow anywhere. So when we started looking around at our sites, we started thinking about it in weeper terms. So we started going, why can't we get this device here? It makes so much sense. It's going to save us time or buy us time to wait for a retrieval, give us an option in between while we're sort of sitting there waiting for a cyclone to pass, or sitting there waiting for the plane to arrive. We started asking around and figuring out why we just couldn't seem to get the device, and we couldn't get training on it either. So we knew that there was a clinical communique in Queensland that around the same time in 2017 had said that if you want to put your patients on high flow, you need to move towards retrieving them. So that created a lot of issues around how we could use it in the Cape and Thursday Island. And then so we decided that we really need to look at the source and look at the problems and see what's going on. So if we were to we asked around, and a lot of comments were around, well, if we get our sick patients, if we ring up Cairns or Townsville to get our sick patients retrieved, are they all of a sudden going to say to us, no, you don't need to retrieve that patient anymore because you've got nasal high flow therapy there? Or is it the opposite way, where it says, does every patient that has nasal high flow therapy need a retrieval now? So we could actually see across Weeper, Thursday Island and Cooktown, which were the main hospitals in Cape and Torres, were that some sites were actually putting it on early and having good outcomes and not necessarily retrieving all of those patients to Cairns or Townsville, and some sites were only putting it on at the very end, the 11th hour, and retrieving 100% of their patients. So we could see a huge discrepancy of its use, and we could start to see the value on, and let's actually research this and see what we can do in the rural remote setting. We also had questions around, the rural remote setting has such a high staff turnover, particularly in nursing and increased in medicine as well. How would we possibly resource this and train staff? What would training look like for us? And what ratios would we need? So we started getting all these questions, and we thought these are really very much context-specific questions. These aren't questions that a place that has like an ICU on site, they would have to really think about. So a tertiary site just doesn't have to think about things like that, so that we inherently do. So that's why we're a bit trigger happy in retrieving really quickly. So we saw the value, and let's research this and see the problem and figure out if there's a way around this or if this is possible. In rural remote settings, in particular for us in the Cape at the time, we didn't have much research going on, and we were a bit research naive, but we had a lot of really exciting projects underway amongst our colleagues. So we developed a research collaborative, and that was unreal, both for us to sort of to sort of cheer each other on and help each other and troubleshoot on the ground. But it also helps us consolidate resources in consumer engagement. And for instance, here we're at the Weeper Bull Ride, and we've got the kidney team there. There was ENT there. There was another OT service that was there, and we were able to just explain to the community what we were thinking about in research and getting feedback in real time, and while doing sort of basic sort of health check stuff. So that was really useful, and we still talk to each other about our research, and it's been very useful in the rural remote context to have those groups. So we decided that we would conduct some research after sort of talking about it for actually a very long time, so probably like 18 months to 2 years, and from the time we started thinking about it. And I was lucky that Alice Cairns had moved to town and that she was really keen on promoting all of these projects. And I think she had a hand in all of these collaborative teams, which is why all of a sudden there was a new interest in research in a small town. So we knew that we'd do it in 3 phases. So the first phase was we'd use an expert panel to develop a guideline for its use in the remote setting, and that guideline would really talk to rural and remote additional complexities. And phase 2, which is really what we're talking about today, is the implementation of that guideline. And then phase 3 will test the implementation. So we have 2 questions. So what are the barriers and the enablers to implement nasal high flow? So we've already started thinking about it ourselves. And in the 3 remote hospitals, those 3 again were Thursday Island, Weeper and Cooktown. And then what strategies can we use to mitigate those barriers and strengthen the enablers of the implementation? We decided on the implementation science methodology. So we then use the IMPRES template by Hull et al. And we decided for this section, for developing these strategies, we use domains 2, 3, and 4. So this 2 is implementation theories, frameworks, and models. And then the 3 is determinants of the implementation, so contextual factors. And then domain 4 is developing those implementation strategies. So we found it really useful using that IMPRES framework. When we were starting out and evaluating what has been done in implementing nasal high flow, we did a literature review, and I'm just going to briefly talk about this just so that you can see what had been done in this space. So we looked at children with bronchiolitis, and that bronchiolitis is because when new research came in the early days of nasal high flow therapy, it was all focusing on bronchiolitis, and it branched out to other respiratory diseases for kids later. So we looked at what is there published about children with bronchiolitis under 2 years old that talks to implementation. And we used the COMBI wheel, so the capability, opportunity, motivation wheel, and we stratified where we mapped where those implementation strategies sat. And you can see that there was lots on opportunity, a little bit less on capability, but very minimal on motivation. And so we could see that health services were excellent at saying, this is what we're going to do. Let's, I'll tell you what we want you to do and how you're going to do that. And then just send it in an email, and that was it. So they were good at putting a guideline together, and then distributing that, and then just walking away. And we found that the ones that had any lick of motivation in them were implementing. Were all from the same study that used an implementation science framework. So we could see that motivation was really lacking in that COMBI wheel. So this study was led by me, obviously, we said that, and I was a clinical nurse until recently in Weeper and in one of the study sites, and the constant presence of me allowed real-time exploration of those barriers and enablers for the provision of care for children experiencing of the children and the experience of the staff implementing nasal high flow. These experiences moulded the research design, and it provided a continual feedback loop throughout the field study. The data on factors influencing the implementation of the nasal high flow therapy was collected over a period of 3 years, so the 2 years before the implementation and then 1 year during it. The pre-implementation discussions with remote health staff, the community members and the nasal high flow experts identified the need of the project aims, the implementation, the barriers, the enablers, and these discussions were documented in meeting minutes and or a field diary. So we had in that first phase, we went through and we developed a guideline for the use of nasal high flow therapy in those 3 sites. This guideline didn't repeat works that were already conducted in statewide guidelines or tertiary guidelines that would still apply to the remote setting. So flow rates, it wouldn't change. We still want that equity in the remote setting, but it did look at the remote additional layers that come up for clinicians when they're using nasal high flow in those settings. And it was an expert panel. It was developed by using an expert panel of 11 participants, and they were formed to support the implementation. And that included rural remote educators, nurse educators, senior medical staff, medical and nursing leaders and retrievals. So the ones that they really had to know about the retrieving aspect to these sites. The paediatric specialists from the retrieving tertiary hospitals, so like Cairns, Townsville Way, and the experts in nasal high flow therapy as well. A modified Delphi approach was used over 3 panel meetings and 1 subcommittee meeting, and that explored the perceived implementation barriers and to develop a consensus on how to manage those barriers that would be suitably addressed in a clinical guideline. So during the implementation, I kept a log of the topic and the volume of queries from clinical staff during formal and ad hoc education sessions and during these clinical shifts. The real-time collation of implementation data supported real-time amendments, and that gave me the opportunity to implement new strategies and solve those problems as they came and went, because we obviously didn't know everything when we first started out. We needed to constantly reassess. So the results from this is obviously the combi wheel, so capability, opportunity and motivation, and then we've got that mapped against the theoretical domains framework. So the result of this analysis were mapped onto the the theoretical domains framework, or the TDF, and obviously the combi wheel. And this real-time mapping process was used by the research and health service staff to identify areas on the combi wheel that where strategies had not been developed, and develop further strategies to address the deficits in the implementation plan. So the final barriers and enablers, implementation strategies, and the corresponding TDF and combi domains were then tabulated. Interestingly, we had equal number of barriers and enablers, and we developed intervention strategies that focused on 5 key areas. So education and training strategies and consultation engagement strategies were our 2 big ones. Then we had resource strategies around logistics, and 1 intervention category that was decision-making strategies, and that was really around the guideline. So we have just put the strategies, we've just remapped them by number on this, like what we've sort of made up at combi wheel, just for a visual representation of how many strategies we had mapped to each combi wheel domain. And you can see that there's a more broad distribution, and but there we have emphasized the motivation domain, knowing that that was highly lacking in the previous strategies. So we have, this is an example of a table that we have been using to use both the TDF and the combi system. We got this idea from a person that had previously presented at this forum, so that was very lovely to attend, and it really helped us figure out how we're going to present this. So so in our first column, we've got the barriers and enablers, and we had relatively equivalent enablers to barriers across, which was very nice to know. Then we've got what the TDF domains map to, and the combi wheel, what that's mapped to, and our intervention categories. So what I will say about training and education, because this is just a snippet of all of it, of the entire table, is that training and education was probably the most resource inducer from my perspective, time and presenting out of all of the strategies, mainly because we had to consider the fact that, first of all, rural and remote sites everywhere have an extremely high turnover of mostly nurses and doctors. We could have, it would be between 50 and 80%, I would estimate, of turnover each week, or at the very least each fortnight. So it felt as though you were meeting a new team, even in the site that I worked in, every 2 weeks. So we also had the issue with the fact that there's so few staff on shift at the same time that always have patient loads. So people don't go to rural remote sites. They rarely go there for, say, like a project. They're always presenting. They're always coming to work in these sites as either agencies or casual in and out staff members to take a patient load, in essence. So we knew that we were going to get trickles each week when we provided education of 2 or 3 people at every site. We also did provide virtual education, but we knew that in order to provide education, we would have to be able to, or at least attempt to saturate the workforce. We would have to be presenting and educating every week to all the 3 sites. We knew that we needed to provide a 24-hour phone consult for all the questions that might come up. We knew that we needed in some circumstances, I would need, when we had a team of us educating at the same time, if we were fortunate to have our colleagues from down south to come up and help, we knew that I would have to go off and take a patient load, sort of relieve a staff member so that they could come to education. And whereas in contrast, our peers from Brisbane would say, oh, we'll get through X amount of staff, so 200 staff members easy. We'll get 20 a session. And I had to say, no, we're going to be getting 2 to 3 people each time, not 20 people turning up. No one is able to facilitate that. We also knew that we had very different degrees of a knowledge-based presentings of the nursing and medical workforce, because rural and remote people don't just specialise on paediatrics. They work across the entire lifespan, and they also, so we had 3 main themes of what we educated on, and in each session we had to figure out what was needed on that day. So sometimes it was all 3 themes. So it might have been the knowledge around the guideline, which was almost everywhere because the guideline should have been used new to everyone. But some people needed to know how to set up the nasal high flow therapy and use it. But some other people from other towns knew how to use it. They just didn't know how to use it in this context. And then some people needed to know real basics around why do we use, like, the physiology behind using high flow before they felt confident with moving up into the how to, and then the how we're going to do it, so in the guideline. So that was really complex. And we were able to travel to each of the sites for both education, but if we were unable, this was during COVID, we relied a fair bit on virtual education, and we also sort of got around, we could almost do everything relatively okay virtually, except for the how to set up. And so we had to mitigate that and get people on the ground to help us set up in real time so that we could answer questions on the go. So the strategies around logistics and resources and strategic decision making were the fewer categories that we had to strategize around, but we had to do it in the sense where we knew that we would have, in relying on retrievals, we knew that we'd have to consider the difficult weather, like the unpredictability of retrievals, like we described earlier. So with that, we knew that we had to provide a method to increase our capacity for caring for these children on site, which is in essence what this project is about. And in regards to resources, there were really interesting things those were the things we had to learn on the go. So we realised that we needed to work closely. For one of these examples was working closely with pharmacy and figuring out how to make sure we had even enough water on site to run the Airvo machine, because it looked like there was lots of resources, say 2 boxes of water, it seemed like a lot, but that might actually have been that would go far with a paediatric patient. And you might only need one bag per child. But once you put one adult on high flow, then that might use that entire supply. And then we wouldn't have water to use the machine with for another week and a bit. So we really had to think about things because, you know, we're so far away, it's hard to get resources. We really had to think about that sort of forward planning things and like, do we have enough oxygen on site and all of those sorts of considerations. And then strategic decision making was really about helping the local medical and nursing workforce figure out the disposition of the patient and how we're going to, if we're going to use nasal high flow therapy on these sites, how is that going to look? And that was really all about putting in that guideline. So consultation and engagement was equivalently high as education and training. So it was really a big one. And that's mainly because we are in a small town. Alice and I didn't want to be run out of town if we were just putting something in unconsultated. We knew that we would have support with the local community member. We just needed to make sure that we were constantly applying that consultation feedback loop. And that's how that collaborative group that we had together was really useful. We knew that Royal Flying Doctors and RSQ were able to use nasal high flow, and we were able to include these organisations in our development of the guideline, but we knew that QAS, Queensland Ambulance Service, didn't have high flow, so we had to think about those sorts of logistics and consult with them as to how we would actually get because we need the ambulance to go to the plane if we're retrieving. How would we get the patient from the health service for that 20-minute drive, if that, or a little bit more, to the airplane? And how would that look with using the machine, and is that okay? And we also knew that we needed to really consult with our stakeholders in town. So like our Aboriginal medical services, our in Weipa, it was particularly a Rio Tinto heavy town, and we needed to communicate with all of the other organisations, primary health centres, who would communicate with the community and make sure that everyone understood, because we certainly didn't want the case where we'd have a patient come through that didn't know that this was possible in Weipa, and all of a sudden being told that they can use nasal high flow, and whether they we wanted them to have thought about that first, and we wanted to make sure that they still understood their healthcare charter rights as patients and consumers, and make sure that they still had the same rights. It didn't change anything if they wanted to retrieve or stay, but it gave them gave the community an option, and they weren't blindsided at the front desk when arriving to the hospital. And then we had to. Oh, and then we just developed the guideline that all had it, and all the community members and the health staff all had felt like they had a personal investment in getting this project across the line. So that was really useful. So what's next is we are looking at our primary outcomes, so our retrieval rates, and we're currently looking at, we're analysing our data that we've got coming through now. And then our implementation outcomes, we're looking at the data from the medical files to see if there's been adherence to guidelines, and also where we've conducted some interviews, and then we're analysing that as well to see how the staff felt about the implementation of the nasal high flow therapy. So to surmise, really, the four most important things that we found in applying anything and implementing anything in the rural and remote context was you really needed a local champion or representatives in any site that you're implementing anything in to really help drive on the ground, and they really need to drink the Kool-Aid, and they really need to sort of get on board like we were. And for the most part, that was easy for us to achieve because people were so supportive of the project and wanted it across the line. And they had a sense of pride about the project also. So that was in a relatively research reduced location there, and we found a project that people wanted to get across the line. We found that was actually very easy for us because people were really proud to be part of a research project of this nature for their community. And then we really needed to come up with some solid mitigating strategies for that high turnover of staff that we couldn't do anything about. And that meant that we just had to constantly be available. And that's what the 24/7 phone line was about. And we had to set up education and strategies to make sure that night and day that people were able to access a way to learn about nasal high flow therapy. These kids tend to come in at very like awkward times at night where there's the least resources available possible to back people up with. And then we needed to make sure we mitigated that cognitive burden for the rural generalist doctors and the nurses. So that is around like that's why the guideline was useful, because it provided immediate approvals for things that they would otherwise need to sort of go around and call someone. Can I call in a radiographer? Can I send this pathology out? Can I, and it also had a really clear disposition of the patient process and consultation, so that these arguments that occur after hours have been done beforehand. You've got immediate approval. So that was really important for us. And in particular, they are things that people don't have to think about in cities. And then obviously that rigorous community consultation was really important, because we didn't want to be perceived as doing unwanted or sneaking in research. And again, nothing is secret in these communities. People know about what's happening, even if you haven't told them. And there would be quite a lot, I think Alice would agree, a lot of contention around research. And I think if we hadn't explained it first or gotten ahead of it. And this is just to represent that this project was a definite collaboration with multiple organisations that we absolutely needed to help us both financially, with resources, with Fisher and Paykel, our grant organisations, and all of the other organisations that helped us arrange for the patient at the bedside to get coordination to get to the tertiary site if they needed it. And with that, I'd like to say thank you and ask if there's any questions. I'll just stop sharing.
Thank you, Sally. That was a fabulous presentation, and I could feel your passion coming through as you were sharing some of those challenges, but also the journey you seem to have gone on sort of in that implementation science space as well, which is just a beautiful combination of the two. If anybody has any questions, please feel free to either put your hand up or pop them in the chat. I will just open my chat actually, just to sort of keep an eye on that. So please do let me know if you have any questions. I'm going to leap in first, if I can, sort of chair's prerogative, if that's okay. And this is going to be a very, very naive question that Alice or Sally, you're going to be able to answer. But you were talking about the financial burden of retrieval. Is that because the retrieval itself isn't funded, or is that to do with the expenses once somebody gets somewhere? What's sort of wrapped up with all of that?
Yeah, I can answer some of that. So the cost of the actual retrieval is funded, and a guardian or parent is funded, but there is only, it depends on how long you're down for, but anything else around that isn't funded. So, you know, cost of food and purchasing food while you're down there, and of course the children in hospital, and that has some, but it never works out as much as easy as that sounds. Also, often people are discharged in Cairns or Townsville, but they might not be able to get home, so they're sent back commercially, and that is certainly funded, but they might need a night or two while they wait for that flight. Now that is partially funded, but the cost of accommodation has gone up, and the subsequent cost for the patient travel doesn't always match it. And then, of course, like I said, the other things around it, like transport and things like that. I guess the other main burden is then sometimes if you're a single parent, you've got other children at home and you're flying out a child, you can't bring your other children with you. So you either need to find somebody else who can look after your children, and sometimes that puts children in quite vulnerable situations. Yeah, or you have to pay for those children to come down, and you have to do that yourself. So, and certainly other parents, so often they'll have another parent will want to fly, and they will fly. They'll have to pay for that themselves. And then there's time off work and all that extra stuff that goes with it. So although the medical care itself is funded, all the bits and pieces around that is not. And that definitely creates quite a financial burden.
And I must say that distress around making those choices on retrieval and choosing, will I take my kids, will I go? Some parents choose because they have no other option for the safety and care of their other children to send the child by themselves on the retrieval, and that's devastating. And just I think that's basically what led me to drive this project from the outset. And I can tell you that it's $60 a day that people get refunded for if they, and it's a refund afterwards, if they have to stay in town. There are some, like say, hostel accommodations that if it's available for people to stay in, and that would have a gap. But that is often an 8-bed bunk room.
Oh.
And yeah, so the options there are relatively limited, and you can really understand why people, it's a big deal for people. And I mean, if you're on only supporting your own family and you have a Rio Tinto job, and you wouldn't notice it. You go, oh, this is just a part of life.
Yeah.
But for anyone else in the community, it's a really big deal.
Yeah, yeah. Thank you, Sally. And Andrea's just popped a question in the chat, and Andrea says, "Great presentation. I agree. Have you got any plans to scale this intervention to any other sites?"
We have. Thank you for asking. We, in essence, by the sort of tail end of this project, we applied as a larger research team for a statewide MRFF grant, and we were successful. Hey. So we are now extending this to, at this point, 16 other sites in rural and remote Queensland. We really, the funders wanted us to supply it for the rest of the state. We just actually had to consider what was feasible because of the cost of travel to roll out these sites is just enormous. And we were a relatively small research team. And so that is actually called Paris on Country. And so that is underway. This time it's an RCT, but using a step wedge methodology, and we're on to our second round coming up.
Fantastic. Great to hear you've got the numbers to do a step wedge. That's great. Right, the questions are queuing up, and we've not got that much time, so I'm going to go straight to Mila and then Seamus.
Thank you. Great presentation. I've got a couple of random questions, but I was just going to make a couple of comments. I think one is, if you have big mining companies operating in town, lobby them for funding to cover the community expenses, if that at all possible. My question is more around, you made one comment was, in planning of your initial study, do you consider doing like a patient journey mapping of what actually happens when a child is determined to need a particular service, and what is the process of getting to the location? Because as you said, government departments are really good at doing a policy or a system or a guideline, and here you go, implement it. I believe strongly that this is why implementation science was born, because the implementation of something that was designed works very differently from its intent. So I'd be keen to hear your initial comments on that, and then I'll ask my second.
Well, I think we did. And that was how we developed who was going to come in on board to do the guideline. But we were relatively new to research then, and we didn't do, say, such a formal mapping process. And then we realized, oh, this is actually a really big deal. Let's put some theories behind this and put a framework behind it. But that we had to map it that way. And I think as clinicians on the ground, we knew the answer before we had derived it. But we wanted to really make sure we hadn't missed things. And we did. We missed a few things in putting that guideline together. Like I would have, Queensland Ambulance Service, we would have put them in there to develop the guideline, but they weren't. They're probably one of the only organisations that weren't in there. So I think that understanding of the context so much sort of led us to make assumptions before doing a formal process.
Yeah, and you made a point to that. It's quite interesting because you said in the rural and communities you have to think of a broader health system risk of the challenges because they're all connected and how it interacts. My second question is, I think you made a little bit of a comment that community was research adverse. Was that the community itself or the research workforce? I was just interested. That was a bit of a unusual comment, and what's the general idea?
I wouldn't say they were research averse. I just think that they wouldn't have been exposed to it before, apart from a horrible history of how we have managed how Western communities have come into Aboriginal and Torres Strait Islander communities and conducted research unethically. What would you say, Alice? Would you have a...
Yeah, I think you're just very sensitive to that history when you're working, particularly Cape and Torres. There's particular community protocols, and it doesn't matter whether you're doing research or other type of projects and stuff. There's really clear protocols, and they're different between different communities about who you consult and who you don't. And I know there's a question in the chat about how did we know. I think the really big takeaway from this is that we lived there and we knew all this stuff. We knew who to ask if we didn't know. And even Weipa is a long way away from Thursday Island, the Torres Straits, and from Cooktown. But because we were so connected to those people, it was easy to ask and get the right information and get the right support. And when we looked at those enablers and barriers, I was shocked to see there was equal numbers, really, really shocked. That was not what I expected. I expected to see tons of barriers and only a few enablers. But because of the, I think, presence of particularly Sally and the trust that was in her, and then in the team, the expert panel team that she had around her developing those guidelines, it was very easy to see the support for the project and support for having staff do the education and to work on the research project more broadly, because she was there. She understood the context and deeply understood it, so was able to really relate very quickly to all particularly the clinical nursing staff that she was having to work with. So it's an interesting process.
Plus we had
amazing work. Thank you.
We had good, strong Aboriginal and Torres Strait Islander representation in our team that really just, I would just say, who should I ask in Cooktown? Can you introduce, or what should I do here or there? And they were just so easy and well known across all the 3 sites themselves. So that really made that effortless.
Let me go to Seamus, who's been very patiently with his hand up there. Seamus, go for you.
Thanks, guys. Amazing presentation. Congrats. I also had a question about upscale. I'm just wondering if you have any thoughts in terms of those and that idea that you mentioned about kind of place-based work. Do you have any thoughts in terms of the determinants of implementation that you identified for this project? Do you have a sense of which of your findings will be generalizable or transferable to other contexts around the state or around the region? Or do you think when you do that kind of local adaptation, you'll have to do much of the same work again to find out the local specifics? And is there a way to tease that apart?
I can talk to this if you're happy, Alice. I really thought about this when we were upscaling, because I was quite cognizant that the majority of the team we were doing this upscale with were tertiary people, and I was the only remote person in that team then. And I was then thinking, don't just think we can just do the same. This is what the whole point was. And I really thought about, are we going to have a guideline specifically for each site? We found a way. But we actually found that we had to factor in different things from every site. So it probably took us the first year talking to all of these sites and figuring out what the key, we just needed to know what we were up against and what the key things were and how they function. We found lots of similarities, which were probably because it's rural remote settings tend to be sort of painted with the same brush by decision makers in tertiary sites. So there are lots of little practical things were useful. For instance, the disposition of the patient, the guideline, most of that was translatable, and we were able to, we're not actually implementing exactly the same thing in this scale up. We've realized what we actually need to do, and this is like a learning point from Parish Remote, was we need to consider the management of a paediatric patient and that knowledge base in general, as opposed to just nasal high flow therapy. So we were able to develop a website that really consolidates and talks to the, say, 42 respiratory care guidelines that city people would know because they only do pediatrics, and then able to make that a one-stop shop on that website for these communities to use, as well as how to use the nasal high flow therapy. But because it's so early in the piece, even when I go to sites, some of the sites now that have sort of been rolled out, we're still learning new things, like, oh, that's not going to work for you, this is going to work for you, and that has been really interesting. Yeah, thank you.
Well, on that note, I'm going to say thank you very much, and thank you for all of the questions. And there's a whole load more in the chat, and I'm sorry we haven't had a chance to get to those. If anybody has any specific questions, I'm sure Sally and Alice would be happy for you to get in contact. Yeah, yet again, fabulous presentation and great work that you're doing up there up north. So thank you very much for sharing your experience and your implementation science journey as well. Look forward to seeing you at future sessions.
Thanks for all of your time.
Yeah, bye everyone.